Good afternoon, everyone, and thank you all for joining us today for our webinar focusing on cachexia and colorectal cancer. My name is Zach Getty, and I am the Patient Education Program Manager here at FIGHT CRC. FIGHT Colorectal Cancer is the leading patient empowerment and advocacy organization in the United States. We provide balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope, focused on funding promising high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. So before we get started with the actual webinar, Cachexia and Colorectal Cancer with Dr. Richard Dunne, I do have a couple of housekeeping items that I'd like to go over. We will have probably a pretty significant amount of time for questions at the end of the webinar. But please feel free while the webinar is going on to use the Q&A panel on the right side of your screen to ask any questions that come up along the way. There is a dedicated Q&A panel to put questions in. Please don't use the chat for questions that you'd like answered at the end of the webinar. And we will do our best to address those at the end after the presentation. We will also have a recording of this webinar available on our site in the next few days. Please keep an eye out on the email you use to register for the webinar, and you'll receive a direct link to that as soon as it is available. And then last but not least, please feel free to tweet along with us. You can use the hashtag CRC webinar to do so. And then please also remember to stop by our website at fightcrc.org to check out all of our educational resources that we have available. This includes Your Guide to Fight meetups, which are an online meeting space dedicated for you to meet with other patients and caregivers. We have our free Community of Champions app where you can connect with other people in the colorectal cancer community, and an assortment of print and digital educational resources that are free to request and download. So a little disclaimer, FIGHT Colorectal Cancer. The information and services provided by FIGHT Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitute for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you're ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. FIGHT Colorectal Cancer never recommends or endorses any specific physicians, products, or treatment for any condition. And now with all that out of the way, I would like to briefly introduce you to our participants. Joining today are Dr. Richard Dunne, Associate Professor of Medicine and leader of the Gastrointestinal Cancer Unit and Clinical Research Program at the Wilmot Cancer Center Institute at the University of Rochester Medical Center. And we have also with us Carol Mantica, FIGHT CRC Patient Education Project Manager and Stage 4 Cancer Survivor. Thank you both so much for taking the time out of your schedules to join us today. I'm going to hand it off to Carol and Dr. Dunne so they can introduce themselves a little bit more, give themselves a little bit of background, and get this webinar started. Carol, I'll hand it off to you.
Thanks, Zach. First, thanks to FIGHT CRC for putting this webinar together about this very important topic. A special thanks to Dr. Dunne. We value you, and we're so appreciative that you would give us your time today here to discuss, again, this important topic on cachexia. A little bit about my background. I'm the Patient Education Project Manager here at FIGHT Colorectal Cancer, but before that, I had many hats that I wear. I'm a survivor myself of stage 4 colorectal cancer. I was diagnosed in 2016, and I'm doing well at this point. Another hat that I wore was the care partner for my late husband, Michael Mancini, who was also a survivor of stage 4 colorectal cancer. Unfortunately succumbed to his illness on March 4th, 2022. But during his fight, he had experienced cachexia. Mike was in the best shape of his entire life when he was diagnosed. He was a fitness trainer. He did all the right things. He made all the right choices, and he lived a really good, healthy lifestyle. He was 170 pounds, full of muscle. He was the guy that always bragged about how his body muscle fat was so good. He was a hero to all of us who knew him. And unfortunately, through the bitterness of his diagnosis, and as the debilitating cachexia as one of his disease progressed, he was no longer able to maintain, because of the metabolic balances in his body, his healthy weight, regardless of what he did. And at the time of his death, he weighed 98 pounds. And so I'm here to share the journey that Mike and I went through with cachexia, to hopefully bring some more clarification to the disease with Dr. Dunne, who is, the leading expert. So I'm glad to be here, and I will hand it off to Dr. Dunne to introduce himself.
Hi, everybody. I'm Richard Dunne. I'm a medical oncologist. I specialize in the treatment of cancers of the GI tract, including colorectal cancer. And I work at the University of Rochester Medical Center in upstate New York. And so my research focuses on finding new treatments for diseases like colorectal cancer, but also to find a better understanding or develop a better understanding of cancer-associated weight loss and muscle loss, which is also known as cachexia. And through that, ultimately developing new and better treatments for this. I got into this line of work when I was in my fellowship. So one of my last years of training, when I had met a patient of mine who actually was kind of almost a similar story to Mike, in that he was very active, very athletic, and the patient just kept losing weight, and he had no explanation for it. And even though his cancer was well controlled with the chemotherapy we were using, sometimes we know that weight loss is associated with cancer progression, but this gentleman's cancer was fairly stable. Tumor markers were stable, but he kept losing weight, so much so that he started coming into the clinic in a wheelchair because he had gotten so weak. And ultimately, it was the nutritional and metabolic disturbances from cachexia that ultimately led to his death, because he had been off treatment for his cancer, and the cancer had not been growing. And this left kind of a profound effect on me, something I didn't really know much about. And when I started to read more, I realized there weren't very many good treatments for this. And so this inspired me to work at this and to learn more about it, research on it, and publish it. And I'm here with you today to obviously answer questions, but also to spread awareness. And so I'm really happy to be here today. And I really want to thank Fight CRC for giving me the opportunity to share my experiences with you today. So I think we can advance the slides. So we'll just go, I'll give just a brief primer on cachexia, but really, as Carol and Zach had mentioned, we want the bulk of the time to be spent with going over questions. So as you see on the slide here, cachexia is a multifactorial disease characterized by weight loss via skeletal muscle and adipose tissue loss. So people lose a lot of weight with cachexia, and not only, I think, more closely is associated with loss of muscle, but people also lose a lot of fat mass. And so both fat and muscle are lost. And this is due to not only decreased food intake due to cancer or to the effects of chemotherapy, but also this uncharacteristic speed up of metabolism. So people go into a hypermetabolic state, as if you're running a marathon when you're actually, not as active, because you can be weakened by this condition. And so you have a decrease in energy intake, caloric intake, but your body is using up all of your energy reserves that you have. And some think that this is due, to the cancer. The cancer is increasing its metabolic rate through a number of ways. And one of the main drivers of this is inflammation. So a lot of inflammation that cancer, and also the treatments that we give for cancer, like chemotherapy, can do. So the current definition of cancer cachexia is a loss of 5% or more of body weight over the preceding 6 months. So if you think about that, a 200-pound male who ends up losing about 10 pounds, it would meet the definition of having cachexia. So it can be subtle. The weight loss can be subtle, and people can be suffering from this. I think we traditionally think of when people think about muscle loss and cancer or cachexia, not just patients, but even when doctors who take care of patients with cancer, they tend to think of very advanced stages where people have lost a tremendous amount of weight, 10 to 20% or more. But this actually is happening earlier on. And so it's something that we want physicians, oncologists, primary care physicians, patients, and caregivers to take note of, as it can be, the beginnings of this can be quite subtle. Other symptoms can be fatigue and decreased strength. So we'll move on to the next slide. So yeah, that kind of dovetails into talking about the symptoms of cachexia. Some are listed here. We talked about loss of muscle, loss of appetite. So I think we know that cancer itself, plus the treatment we use for cancer, can lead to loss of appetite. And this is very closely associated with loss of weight. When our patients do not have the same appetite, or they have what we call early satiety, they get full very easily. And that ultimately leads to decreased food intake. The weight loss is unintentional. So we talked about 5% or more of weight loss as a definition of cachexia. But the key is that it's unintentional. So somebody who is a colon cancer survivor who wants to eat healthier and exercise, and they end up losing a few pounds because of positive changes in their lifestyle, would not necessarily be considered as being cachexia. So it's unintentional. Fatigue is one of the more common side effects. I think it's in general if you think about cancer associated fatigue, it can happen in upwards of 80% or more, depending on what study you look at, of patients with cancer in general. So fatigue is very common, whether you have cachexia or not. But fatigue and a reduction of someone's daily function is a very common sort of issue. So fatigue, and then seeing, well, someone was working before, but then is no longer able to work, or someone was able to prepare meals and live independently, but is not able to do that anymore and is spending more time resting in a chair or laying in bed and needing to have more help with the activities of daily living, like preparing meals and bathing. So fatigue and a loss of function are common hallmarks of cachexia, and one of the reasons it makes it such a debilitating disease. And then lowered quality of life. Quality of life has can have sort of a broad meaning, and can have it can touch different aspects of people's lives. But our patients with cachexia are often able to do less. As I said, their function might not be there. Patients who have cachexia often have advanced cancer, maybe dealing with pain. They may not be able to enjoy the foods that they used to like, either due to appetite or they get full too easily. And so in studies looking at the lives of patients with cachexia, found that there was lowered quality of life. And so you look at these things are very, very important to our patients' lives, if they're living with cancer on cancer treatment, and then beyond in the survivorship as well. And so looking for ways to improve this has so many important implications, not just for quality of life, but for ability to receive chemotherapy and be strong enough for chemotherapy, to be able to receive ongoing therapy and ultimately have better outcomes from their treatment for their cancer. You can go to the next slide. So cachexia is actually very common. As I had alluded to earlier, it can be, even as subtle as of 5 to 10 pounds of unintentional weight loss, depending on what the weight of somebody is. And so I think it's more common than we know about it. And some of that is, it's not something that doctors really talk about. Patients and their family members might not be aware that they have this, what it's considered a syndrome that is associated with their cancer. Some of the symptoms of cachexia are kind of just sometimes thought of, oh, that's just part of cancer, or that's just part of chemotherapy. But in fact, there is something happening within one's body that is changing, that is responsible for these changes. When thinking about diseases where it's most common, pancreatic cancer, cancers like stomach cancers and esophageal cancers and lung cancers are often cited as the most common cancers that are associated with cachexia. However, it is quite common in colorectal cancer as well. I think it depends on the research studies that you look at and the populations of patients where this is studied. So in earlier stage colon cancer, stages 1 through 3, patients that have surgery for colon cancer, it can be, from 10 to 30%. But in patients that have stage 4 colorectal cancer, it can be as high as 50%. And so this is something that is obviously very important for cancer patients with cancer and their caregivers in general, but particularly for this group and fight CRC. And so we think that there are hundreds of thousands of people and possibly more that are suffering from this each year. And as of now, there really is no one standard treatment that we point to. I think if you think about a disease like colon cancer, I'm sure many of you on this call know about FOLFOX and FOLFIRI and the different ways that we use chemotherapy and targeted treatments to target colorectal cancer. There's almost a roadmap for oncologists in terms of, and there are certain guidelines of what is the best available treatment. For cachexia, there's no roadmap. There's actually no FDA-approved treatments currently. And so the treatments that we provide for this are aimed at tailoring treatments to improve symptoms associated with cachexia. But I think until we are developing treatments that are targeting the underlying biology of cachexia, much like we've done in treating cancers, we're not going to make as much significant headway. So that is why research and developing treatments and clinical trials for this condition is so important. I think we can go to the next slide. So Carol, I don't know if you want to take over here.
Yeah, so thank you, Dr. Dunne. That was so thorough and it about wiped out all of my questions. I
left out some of my answers so that we could get into more in depth in some of these topics.
Good. I do have a few questions to pose to you. And a lot of what you said spoke really closely to what Mike suffered from. I think a lot of times we referred to it as he had, like he was the host to this parasite that he, just couldn't fight off, and he fought it off and battled back and fought it off and battled back. But his metabolic state was just so compromised that he just couldn't find the way to, no matter what he did, no matter what he put in, no matter what he ate or didn't eat or how much he worked out in the gym, he just couldn't capitalize because it, again, was like that parasite host situation going on in his body. So thank you for all of that information. I think that one of the most important questions is going back to the definition of cachexia. We had a definition that, that we posed, but is there something else that you would, is it adequate first? Is that definition adequate? And then would there be anything that you would want to add additionally to that definition of cachexia?
Right. So what we alluded to was kind of more of a diagnostic criteria. So, if someone has X, it means they have this, syndrome. The operational definition is, and we got into a little bit, so it's a multifactorial syndrome of loss of weight is the primary thing that characterizes patients, mainly due to the loss of muscle mass, but also fat mass. And I think one of the, in that definition or addition to it that is very important is it's associated with functional impairment, which I was talking about as the symptoms in terms of fatigue, functional impairment, but also I think is key, and to what you were speaking about of having hard time overcome, key to that definition is that it cannot be reversed by traditional nutritional support or conventional nutritional support. So this is not something that can be overcome just by eating more. So the metabolic demands that patients with cachexia have are so great that eating a second helping, or what has been tried in the past is putting a feeding tube into somebody and trying to give them, either get them to their daily needs or give them more calories, has not been effective. And actually the American Society of Clinical Oncology, ASCO, that many of you may be familiar with, had put out guidelines actually in 2020. And that was one of their recommendations, was recommending against any sort of feeding tube because it has been shown not necessarily to be helpful. And the guidelines, they're available. They kind of show how far behind we are, because they couldn't recommend any sort of pharmacologic or drug treatment that could be recommended for most patients, because the data just isn't there. And so the guidelines are underwhelming and disappointing because we're just behind as a field, and the development of therapeutic strategies and novel treatments is urgently needed.
Yeah, thank you. So I think the difference is the metabolic space, right? Like we suffer weight loss, but cachexia is a resulting weight loss that we can't treat. We can't put extra gains in, we can't put extra proteins in like we can some of the other other types of weight loss that we face with disease, with cancer. We discussed some really briefly telltale signs of cachexia, things that you notice. I mean, I think as a patient, when I see that, I think the first thing I think of is, well, how can I prevent it? Can you speak on that at all? Is there a prevention protocol, or what can we do as patients?
Yeah, I think this is a great question, and one that we're really focused on is trying to recognize this early and trying to treat early or get ahead of it. And so along with this, so this definition that we've alluded to was developed by an international consensus of experts about a decade ago. And they're actually working on updating the definition to at least be a little bit more specific than just a parameter of weight loss. But as part of that definition, they created this classification system of cachexia or pre-cachexia, cachexia, and severe or refractory cachexia. One of the things that seems pretty clear is that it's irreversible and refractory to any treatment when it's at its end stages. So for folks who may be at the end stages of cancer, unfortunately, and they're losing a lot of weight, it can be hard to keep up and hard to mitigate or slow down any of the weight loss. And so a lot of the research that my team is focused on is really in trying to recognize this from the get-go, possibly from either the first or second visit with the oncologist, and in terms of clinical trials and characterizing is figuring out what's happening early on in the cancer diagnosis. There are probably things that are actually happening in the body years before the cancer is actually diagnosed. It is hard to study folks before they're diagnosed with cancer, before they present it to a physician. So we try to focus on that early diagnosis period. We think that's the right time to work on someone's physical activity, work on someone's nutrition, get nutrition counseling. And so, although if someone comes to see us and they might have lost, 20 pounds in the last few months, having them get back to that weight that they once were, that may not be possible. And so we really focus on trying to maintain. And if we can get, add a few pounds back, we'll be happy with that. But I try to focus really on trying to keep things the same. So I think one of the things that was in the guidelines and one of the things that the data has shown to be helpful is early counseling from a dietitian. And so, it's not that people need to do fad diets or do some extreme diets, but it's, meeting with a trained professional about learning about what someone's caloric needs are, learning new ways to eat and get the intake they need when sometimes it's hard, when people are on treatment, when someone is anxious or worried about what might happen. It might be hard to get in those calories. So meeting with a registered dietitian early on, that can be tricky for people getting their care out in the community and not at a university hospital. So I think connecting with, if someone doesn't have access, connecting with certain patient advocacy groups to get information on how someone might be linked in with a dietitian may be helpful. The other thing that we see is a decrease in physical activity, and that could lead to loss of function. It could lead to muscle atrophy. So we recommend our patients to stay active. Now, I think we caution people that we don't expect them to be running marathons, nor would we want them to, because very rigorous cardiovascular exercise may compound the weight loss. But doing light to moderate intensity activity is safe in patients with cancer, and there are studies that have shown that, and will help preserve function. The other thing that is key is making sure that your symptoms of cancer and your symptoms of cachexia can be managed the best they can. So that is, if someone is having nausea, that's interrupting their eating, it's addressing their nausea. If someone is having issues with their bowels, they're losing a lot of weight because of diarrhea, is managing that. For some cancers like pancreatic cancer, we make sure that they have proper pancreatic enzymes. And so working on the symptoms related to cancer, and medications that might help with nausea, possibly help with appetite, are things that could be tried early. They're not necessarily specific for cachexia, but they're addressing things that make cachexia and weight loss worse. And so identifying it early doesn't hurt to discuss this with your doctor. I've read about cachexia. What is that? How can I help? Now, some might not have an expertise with it. Some studies have shown that some are uncomfortable talking about it. And so, but it's never the wrong time to bring it up. And if it's not cachexia, it's asking about my weight. What do you think of, asking your doctor, what do you think about my weight? What do you think about my nutrition? And that can kind of get you in the right place, or they could at least lead you to being referred to the right people.
Absolutely. You answered like some of the most important questions that I could think of when it came to, I guess my personal experience with cachexia. We, Mike and I presented cachexia and the idea, which, Dr. Dunne, we presented it to our physician, and he didn't think that it was anything that Mike was experiencing. And then through our advocacy work and our investigation of our own, we discovered it actually was a thing. And so my question, I only have 3 more questions, I promise. We'll send it off to the Q&A, but my question is kind of to that point. You're looking at your physician and you're having these conversations early, which is a good opportunity to work towards some prevention, and putting some things in place that can benefit you through your treatments and through dealing with cachexia. You mentioned the dietitian was an integral part of the team that you would advise a patient that is considering that they might be having symptoms of cachexia to putting them in place. Are there any other situations or people in the patient's care team that you would feel would be a vital resource to integrate into that conversation?
Yeah, I mean, I think having a team and having a different expertise and different people helping, I think is essential. This is something that I focus on almost every day, but yet I know that I couldn't do it alone in terms of helping patients through this. And so I'm lucky enough to work with some great people that can help our patients. So I think early referral to a registered dietitian is important. Obviously the doctor or the oncologist might be kind of the quarterbacking all of this, so that's a member of the team. Within that team, important, I think, is our nurses and our nurse colleagues. They often are the ones receiving the messages or sometimes getting pulled aside to talk about, from family, to say, hey, there's this symptom that so-and-so has been dealing with. And, they may be afraid to talk about it, but I'm really worried about this. So our nurses play such an important part in understanding what symptoms our patients are going through. And along that, with the doctor, advanced practice providers as well. In terms of other members of the team that you may not be regularly exposed to, is our palliative care specialists, in addition to being great experts in pain management and symptom management, often do have expertise in helping patients with cachexia, whether that's managing symptoms like pain and nausea, which might actually help food intake. It could also be using medications that help appetite, or it could be just hearing, and listening to patients, kind of what they're going through, and relaying this back to the primary team, oncology team, to as another kind of set of eyes and ears of, do we need to make adjustments because someone is suffering in this sort of way? So I think of palliative care specialists as another ally, especially if you feel like this is not a comfortable subject, maybe for your oncologist to speak about, is asking for a referral to palliative care. Physical therapy or physiotherapist has been another sort of ally in terms of developing safe physical activity and exercise routines. Some medical centers have exercise physiologists, or they have resources in terms of exercise classes, or someone that you could talk to learn about doing safe physical activity when dealing with cancer. So I think about those members of the team as being people and resources that could help as well.
Thank you. Yeah, I think integrative medicine is essential. And and from my experience with Mike, we invested in palliative care right away. And I think that was one of the big things for my experience with cachexia, was that, Mike kind of suffered in silence in a way. Mental health is really hard. We're already dealing with this cancer diagnosis. And then, we're also faced with mental health issues when it comes to, what's going on with my body and how do I talk to people about what this is. And Mike was eating, he was enjoying food. He didn't not want to eat. He wanted to do all the things. He just, no matter what he did, the intake wasn't enough. And so I was hoping that maybe you could speak a little bit on the mental health piece of what cachexia looks like, and really how a patient essentially could use the palliative space, use the mental health space to talk about their experiences to, their peers, their colleagues, their families, their friends, to diminish some of those, kind of heavy things about what's going on with their body.
Yeah, this is I think a really important part of all this. We talk about physical changes that happen. with cachexia, but it also is associated with mental health challenges as well. And so there can be some patients that might even take on blame of, why is this happening to me? It's because I'm not doing enough. And I think as a doctor, one of the things that I do and what could be helpful as a caretaker is to say, this is not your fault. This is happening. There's a physiologic change that's happening in your body due to the cancer, due to the treatment you're receiving. And you're doing the best that you can. But this, and sometimes actually it's been really helpful for me as a doctor to actually give some context of what is happening with cachexia, what is happening in the body, saying, well, now I understand that better. And knowing that there's this process going on makes me feel better about it. Even if even if we're unable to make significant changes, just having that information has given some people some more peace of mind. I think nutrition and food and illness and family can get very complicated. And so I think Carol's heard me talk about this before, but I think as family members and I've taken care of family members that have had cancer as well, we often show our love through food, whether it's buying someone's their favorite meal, or for many, their love language is cooking. And I think we often think we're helping by saying, here's this food, please eat it. And it can create a lot of tension, especially if somebody is not hungry, or they get full easy, or food makes them uncomfortable. Sitting down at the table in front of everybody can make someone with cachexia feel uncomfortable. And so I think talking to patients, saying it's okay, you do your best in terms of eating, but also having conversations with caregivers and families that it may be counterproductive to be pushing folks to eat, and making sure people know that they're cared about, that you could help them with the types of foods they want, and kind of soften the encouragement other than placing pressure on folks can often be helpful in terms of minimizing the impact that this condition may have on someone's mental health.
Yeah, thank you. Such important advice, such important advice. I love what you had to say about that. One more question, I promise, and we're done. We'll pass to Q&A. I want to know about the cutting edge stuff, right? We're here at Fight CRC. We support research. That's our thing. We want to know what's going on. We want to know what you're doing. You talked a little bit about it earlier, but I want to know, what you're doing and what it looks like for standard of care in the future, and with the hopes of, ending this piece of the puzzle when it comes to debilitating disease. So if you could just finally, last question, speak a little bit about what you're doing and a little bit about your research.
Yeah, so just some brief context on the history. I think we've known that this has been a problem forever. I mean, it's described hundreds and thousands of years ago by old, doctors in Greece. And with the improvement in cancer care in the 90s and 2000s, there actually have been a lot of studies decades ago using medications to try to alleviate this. And a lot of the trials were really focused on appetite stimulants, steroids, things like cannabinoids or cannabis, and they've really been unsuccessful. In the 2010s, there were several actual phase 3 trials that looked promising, targeting some underlying kind of hormonal signals that may be involved in eating and cachexia and cancer. And unfortunately, they were negative trials, and these drugs weren't developed. This kind of deflated this field for a few years. We were looking for answers for drugs. And I will say that in the last couple of years, really the last 3-4 years, I am a lot more encouraged by the development of drugs and clinical trials that are not just drugs, but also treatment strategies, combining supplements with physical activity. So we're seeing some of these strategies advance into phase 2 and even phase 3. And I think they're more focused, and which is key, on the underlying biology of this condition. Just trying to enhance the appetite, as we said, won't necessarily reverse all this. And so I think over the next 5 years, we are going to have something that is FDA approved in the United States that is better than what we have. Is that going to be that home run that reverses it for everybody? Probably not, but it really takes incremental steps. And so I am very optimistic, and myself and some of my other colleagues who do this research are involved in some of these clinical trials across the country. There is also an increasing, as we said, increasing awareness, but there's an increasing awareness from bodies that support research. And so there are the National Cancer Institute, patient advocacy groups, different pharma companies are very much more in favor of supporting this type of research than they were 20 years ago. And so I'm part of an international team. We are funded by the National Cancer Institute and the Cancer Research of the United Kingdom. And we were awarded a large award to work as an international team to specifically study cachexia and unearth some of these things that we don't know about the biology of cachexia. And so my purpose really is to lead a national observational study where we actually learn more, get down more to the biologic aspects of why this is happening. And there are some that think the definition may be too broad. And our goal is actually to understand if there are actually multiple diseases of cachexia within one. Are there multiple subtypes? And the ultimate goal is that we actually have multiple subtypes of this disease that can be targeted with more specific therapy. So much like we've seen in colon cancer, where we look for KRAS, where we look for HER2, where we look for MSI high, and we have specific drugs that we use to target that. That is what I'm hoping that we develop, a precision medicine platform within cachexia. So in addition to the drugs that are being developed now, but so that we can also have a better platform for designing the clinical trials of the future and become better and more precise.
Awesome. Thank you so much, Dr. Dunne. We appreciate all your input, your time. I think that's all my questions. I think I got them all covered, and I really appreciate you taking the time to be so thorough in answering all of them. I'm going to throw it back to Zach now for the Q&A for the rest of the time we have together.
Absolutely, yes. Thank you, Carol. Thank you, Dr. Dunne. Very thorough, very interesting. I appreciate all that. So I'd like to open it up for the next 15 minutes or so for a Q&A section. There is a dedicated Q&A box that should be on the right side of your screen. Just feel free to type your questions in there. We will answer them as they come, and we'll just try to get as many as we can as we go. And I actually just had one pop up here. It's kind of long, so I'll let you know when I'm done reading the question here. The mental health aspect is paramount in my own fight right now. Diet is confusing. There's so many different options on what's good for me versus what's good for cancer. It's overwhelming and leaves me unsure of what to eat at all. It becomes an unintentional slippery slope. I've lost another 10 pounds in the last few weeks, and not for lack of trying to eat healthy though. The dietitian does sway away from fat diets, and then other opinions come in, and I feel pressure to not eat anything dairy, non-organic, no sugar or added sugars, no wheat or gluten, only raw foods or juice that don't agree with my gut. How to mitigate opinions versus facts, fear versus common sense, and that alone might give me back my appetite.
Yeah, I mean, this is an all too common thing I hear from folks every day in my clinic. There's just so much information out there, whether it's on the internet or just from people who are really have good intentions in sharing their opinions of what is going to help somebody. I think we all have friends and family that want the best for us, and they might have tidbits of information or something they read that they want to share with folks. And so I think one of the things that the guidelines for cachexia talks about, and I alluded to it, was trying to stay away from extreme diets where they're focused on, one type of one type of food, or one type of, whether it's cutting out, one thing and just focusing on one food group, or focusing on, you mentioned juicing and things like that. So, but like trying to stay away from fad diets and focus more on, traditional, better balance that includes both fats and proteins. And I think dietitians, in general, if you think about cancer, non-cancer, will kind of steer clear from fat diets. But it may be helpful, actually, and I don't know if this is the case, but to seek the opinion of a dietitian who's involved in taking care of patients with cancer, as they might have a different perspective. I try to recommend keeping the diet and the options actually as broad as possible. I know there's a lot out there about removing sugar as a way to improve cancer and the cancer outcomes, but we don't know that for sure. And our body makes sugars for our cells if we don't take in any glucose. So, someday we might have a more specific diet for shrinking cancer, for improving cachexia, but right now we don't. And so I usually recommend that people liberalize their diet so they have more choices, so they have more opportunities to get calories, protein, fat in. People are happier with that as well. Now, it is helpful to have that advice of a registered dietitian who can look at your chart, understand what's going on, and also get the opinion of your doctor who's involved in your care. But I tend to try to liberalize things until we know more about a specific diet that's better for a type of cancer.
Thank you, Dr. Dunne. All right, I will leave the question panel open for the time being. I have a quick question. Does treating the underlying cancer always treat the cachexia as well? If you address the cancer, does the cachexia follow as well?
Yeah, that is actually a great question. And I think that was kind of like the old adage, like for decades was, cachexia was just because the cancer was growing, and we don't need to worry about that. We treat the cancer and that takes care of itself. There is I would say some truth to that, because we see when patients are losing weight and they have surgery to remove the tumor, sometimes things, do get better over time, but they're not always completely interlocked. So the example I gave of what inspired me was a patient who actually had stable cancer, and they actually died of progressively more cachexia and malnutrition. And so we do see that if someone is having a great response to cancer, they might gain some of their weight back, or they might gain some of their muscle. So I think the tumor does play an important part. And I think it's one of these things that is so complex. We have some ideas about the underlying biology and why it happens, but I think it's not completely clear. So I think controlling the cancer actually is an important piece, but it's not the whole piece. And so treating the cancer, but also trying to manage symptoms from whether it's the cancer or the treatment is important. And then the thing that the research is really focused on now is trying to target underlying biology of why the body is so hypermetabolic and trying to slow that down. So I think it'll be a combination of treating the cancer, making sure people are getting adequate nutrition and physical activity, symptoms being managed. And I think at some point we'll want to develop a strategy to target that underlying cachexia that's happening.
Thank you. It's very interesting. All right, I've got a couple that came in. What are your thoughts on the role of the microbiome in cachexia and the possibilities for personalized treatment / approaches here, and the potential role of probiotics in influencing the trajectory of metabolism and digestion?
It's a great question. I think the microbiome has gotten, a lot of attention in cancer research recently, particularly in colorectal cancer, particularly in immunotherapy and understanding, how that might enhance the response of immunotherapy. And it certainly has gotten some attention in cachexia research as well. I could say the jury is still out on whether probiotics or changing the gut microenvironment can necessarily help. There is some suggestion that it may help in mice. And so as part of a member of my team that I was alluding to, so I kind of run this clinical trial, observational trial aspect, but we actually have a bulk of our team members are focused in the lab in understanding the biology of cachexia. We are actually looking at the microbiome in these patients. We're collecting stool samples in our patients, but we're also looking at the microbiome in the lab, particularly in mice. And so my hope is that we will learn more over the next couple of years, and that is definitely an area that we're focused on.
We've got just a couple of minutes left, everyone, so if you do have a question, please try to get it in. I do have two more actually. The goal is to identify patients early in diagnosis and manage so you prevent the decline. What percentage of patients are diagnosed early enough in their disease where there is an opportunity to identify signs and symptoms of cachexia early and prevent them from going down to the refractory phase? Many patients indicate that they lost significant weight before diagnosis, and that's in fact what brought them in and led to the diagnosis.
Yeah, I think there are many cases, right, where we see that someone lost weight and it led to a scan. And so you're right, this is absolutely a common way that it presents. Knowing the statistics of how many people are caught early and how many catching it early prevents its decline, I don't know if that's a number that I or anyone could actually put out there. In terms of one of the studies that looked at early dietitian referral, patients on average either maintained or gained about 6 to 8 pounds more than people that didn't get to see the dietitian as early. So we know that certain interventions and awareness or a focus on this can help, but I also acknowledge that our treatments for this are not good enough, and the treatments are lacking. And so I still think, despite what we know from some research studies that might help, I still think the majority of patients who come in losing weight will lose more, especially after they start that first cycle of treatment. I think weight loss is pretty common. And so as I mentioned earlier, what I really focus on is trying to maintain, and maybe that's maintain the weight after the first cycle. But we do see patients who improve, whether it's because their cancer is well controlled, because they focus on their nutrition, whether they got good counseling. It is common, and as the first couple of months go in, it actually gets more common. And I think some of the research we've shown is that most of the changes that occur if people are going to develop cachexia is the couple months before their diagnosis and the couple months right after. And so that's why we're focused on that, because most of the changes will happen earlier on. And so until we have a standard treatment that is tested in a phase 3 clinical trial, it's hard to come up with some of those exact numbers.
I just have a quick question, Dr. Dunne. On the data side, is there any correlation with like MSS versus MSI and that being a driver in like if you like get severe cachexia or not? I'm just thinking about with Mike and I in our experience with us both being survivors, and we were opposite on the sides of the spectrum. He was MSI, or excuse me, I'm MSI, he was MSS. And I'm wondering if, because I didn't have cachexia nor suffer in any of my disease space, and Mike did, is there any correlation or data that says that or no?
Not that I'm aware of.
Okay.
What is interesting though, about people who have weight loss or muscle wasting and get immunotherapy. For some reason, the drugs will clear sooner in patients that have muscle wasting. And so there's some worry that immunotherapy is less effective in patients with muscle wasting. Our body compartments, our lean mass, are very important for how we metabolize medicines like chemotherapies and immunotherapies. And there have been several studies showing that patients who have muscle wasting actually have worse responses to chemotherapy. And there's a worry that that might happen with immunotherapy as well.
Thank you. I do want to be sensitive of time. We've got about 5 minutes left, but I do have another question in the Q&A I'd like to. So I am a stage 4 colon cancer and currently stable. I've lost 44% of my weight in about 7 months. I'm hovering around 100 pounds right now. My team is confused as to why. They've done all sorts of scans and blood work and set me up with a dietitian. One doctor told me to eat donuts and other high-fat foods just to see if I could gain weight short term. I couldn't, and now I think they've all given up. Is it even worth mentioning this to them at this point?
I mean, when I hear this, I mean, I feel for you. And it does sound like your team is concerned, right? So they're sending you to see a dietitian. They're doing a lot of tests to make sure that it doesn't represent that the cancer is worsening, which is what I think a lot of us fear when the weight loss continues. I tell people it's not the worst thing in the world to eat fats. We lose muscle mass, we lose fat mass. And so restoring that fat mass is important, just like improving the muscle mass. As much as this is not medical advice, not knowing the details of your situation, as I talked about earlier, and kind of in broad strokes, that having a palliative care physician as part of the team, can sometimes be helpful. I don't think I would, if it's affecting your life, we never want to, give up on that. We want to look for new ways to improve your appetite, improve your weight if we can. And sometimes a fresh set of eyes can help with that.
Thank you very much. So we've got about 3 minutes left. I would like to go ahead and thank Carol and Dr. Dunne for taking the time out of their schedules today to be with us and to host this webinar and to really just provide some really informative information. If another one comes in here in the next few seconds or so, we can get it answered. But I do want to state Fight Colorectal Cancer's mission. We fight to cure colorectal cancer and serve as relentless champions of hope for all affected by this disease through informed patient support, impactful policy change, and breakthrough research endeavors. And I would also like to point out that to everyone that registered for this webinar, everyone that attended, I will be sending a linked copy of the video or a link to the copy of our video on our website. And if you have any questions that didn't get answered, please feel free to respond to that video and I can address those when we get those answered for you. But thank you to everyone for joining us. We have somebody in the Q&A saying thank you, Dr. Dunne. But yes, thank you for taking the time out of your day. We really appreciate the insight and education you're able to give us. So thank you very much. We appreciate your time.
Thank you for having me, and take care.
Absolutely.
Thank you. Bye-bye.